Hi, Dr. Armstrong.
Hey, Darryl, how are you today?
I'm good. Hope you are too. Can you tell our audience, and welcome to our conference. We're totally grateful for you being here today.
It's a pleasure to
Can
be with you.
can you tell our audience what you do and where you do it?
Sure. For the past 15 years, since 2006, I've been down here at Duke University. I'm a medical oncologist that specializes largely in prostate cancer. So I oversee clinical trials in largely men with advanced prostate cancer. I run a laboratory, so I do translational and basic research, but mostly I see patients and try to take care of them.
Great. And so we'll pick up whenever there's a term that seems unusual. When you say translational research, I mean, it's not like taking English to Spanish. What does that actually mean?
That's right. It's a great question. So when we talk about research, there's many different types. There's basic, which is fundamental, science, working in the lab, tinkering, mechanistic studies, trying to figure out how cancer works at the very fundamentals. Then there's clinical, which is like a clinical trial, trying to figure out if a drug or a therapy works in people. And then there's something in between, which is translating what we learn in the lab into the clinic to help a broad population of men obviously do better. And there's also something called reverse translation, which is where you take what you learn in the clinic and bring it into the lab to inform on research that can go back and forth. So it's always a back and forth process. So we use as our motivation the patients in front of us and what they're struggling with, bring that into the lab, inform our experiments, design experiments that can help us understand what makes prostate cancer tick. How does it spread? How does it develop hormone resistance? What causes it? How can we treat it better to guide more precision medicine approaches? And then bring that back to those men to help them live longer and live better.
Great. And just like in 30 seconds or less, an example of where a clinical understanding led to an investigation?
Sure. So a clinical understanding that's very important right now is our men who have a BRCA2 mutation, where we learned through clinical studies, genetic sequencing, that some men have this hereditary form of prostate cancer that they may have inherited from a mom with breast or ovarian cancer or a dad with prostate cancer. These are familial syndromes. And then we brought those findings into the lab to figure out what drugs could kill tumors that have these inherited DNA repair alterations that could make the cancer more vulnerable. These are aggressive tumors. That led to the development of a class of drugs called PARP inhibitors, olaparib or Lynparza as an example, that was brought back into the lab, and a big clinical trial was completed about a year ago that demonstrated that approach improves survival. And now we use it in the clinic. But we're also trying to understand now what drives PARP inhibitor resistance or other therapies that target these pathways. And so we're bringing that back into the lab. So it's an iterative process. You keep advancing as you develop therapies that are successful. It brings up new questions.
So we'll get into PARP inhibitors in a second. And part of today's theme is not PARP, but part of today's theme is why should a patient have confidence in what a medical oncologist is telling them, especially in 2021, 22, 23, when there are, probably a dozen possible combinations and opportunities for intervention that barely existed 4 or 5 years ago. It sounds like when a patient goes for a consult, sits in a doctor's office, in a medical oncologist's office in particular, it's not just about what can you do for me, but it's also this back and forth about, this is what's going on for me. Can you and your colleagues and the world of medical science fix this?
Yeah.
It's almost like you're doing a clinical trial in a way, or something, or contributing to research just by showing up in the doctor's office.
Yeah, consultation, typically lasts for about an hour and for a new patient. And when I engage for the very first time with a new patient, I try to understand them as a person and try to explain to them the situation they're going through, not using a lot of scientific jargon, but to help them understand, the enemy they're facing in their disease, the various menu of treatment options, understand them and their medical issues, their preferences, their choices. And the menu is going to be different for different patients, based on their prior therapies, their other health issues, their age, comorbidities, and, how their disease has progressed, the various stages that cancer of the prostate can progress through, the pattern of spread. There's all sorts of different factors, and even their genetics is now a major factor in treatment selection. So, the first part of the consultation is, a back and forth dialogue, them telling me about themselves and me listening, and then me asking questions as well to get to know them and their preferences, but also to explain things so that they can understand the disease they're faced with. So it's always a good idea to go to your doctor, especially a medical oncologist, with a good list of, key questions so that you can take away from that, a menu of options so that you can make a decision. It doesn't have to be at that minute. You shouldn't be under pressure to make a major life improving decision, perhaps at that moment. But to take that back, either if it's a second opinion, take it back to a doctor that you've had a long-standing relationship with, or to get a follow-up visit to keep asking those questions. Think of the medical oncologist as somebody who's part of your team. You may have been cared for by a urologic oncologist or a radiation oncologist. And if your cancer has relapsed or is very advanced where you need medical therapy, that's what medical oncologists do, is they give medicines. The medical oncologist is going to be integrated as part of that team. So I kind of explain that and how we work together in what's called a multidisciplinary fashion. There's different disciplines, different ways of attacking cancer, and medicines are a key component for that.
And by multidiscipline, I mean, you have one discipline in a global sense. I mean, you're aware of lots of different things, but do you bring in other doctors, other nurses, or specialists?
Right. The various disciplines that treat men with prostate cancer, certainly surgeons, they cut out the prostate. Radiation oncologists can radiate the prostate either with seeds or external beam. They can do that either instead of surgery or after surgery if there's a relapse. Medical oncologists use hormonal therapies, chemotherapies, immunologic therapies, PARP inhibitors, radium, probably PSMA lutetium in the coming months. We do a lot of precision medicine, genetic testing, but largely we do a lot of explaining and talking. That's kind of our forte. We do a lot of consultations around these choices. Urologists, as you know, are very busy operating all the time. And, honestly do have a limited amount of time to spend with patients. So medical oncologists, their role is often to help navigate for patients, this complex treatment decision. There's other specialists. There's palliative care physicians who can get involved for symptom management. There's primary care doctors who really know the patient and their health conditions and may be asked to continue to manage patients and some of the side effects of our therapies. And prostate cancer, fortunately, is the number one survived cancer in America. So a lot of the survivorship issues are best handled by the doctor who knows them the best, that primary care physician. There's also nurses, nurse navigators, and a wide range of other, consults and specialists, depending on the health of that patient and other medical conditions they face.
Yeah, the paradox of prostate cancer being a long living cancer diagnosis is that you have so many opportunities to do things.
That's right.
And yeah, and as you just sort of reeled off a mind-blowing, half dozen of different things, and then, within that, each of those, there are probably 3 or 4 different flavors of each.
Yes.
I mean, it's like, what's going on? What do we do? When I got diagnosed, it was either surgery or radiation, maybe 1 or 2 other different things, but it was a very clear thing. And my goal would be avoiding side effects. Now it seems like the prevailing side effect will be death, but there are other issues that you, as a medical oncologist who's aware of all the different effects of all these different kinds of medicines and therapies and how you sequence them, which comes first, which comes at the same
Yep.
time. Um, how do you do that?
Yeah, I think it's important to realize that a patient doesn't have to become an expert in 30 minutes. And not all patients need all the information on all the therapies that may not be relevant for them at that given time. It has gotten increasingly complicated. 15 years ago when I started down here at Duke, we did talk about relatively simple surgery, radical prostatectomy. The robotic procedure was just becoming in vogue. We had several types of radiation. And all we had at that time for life prolonging therapy in the hormone resistant patient was maybe docetaxel. So not a lot on the menu besides hormonal therapy. And then since that time, we've had many new therapies. We got abiraterone, enzalutamide, got apalutamide, darolutamide. I could roll off about 10 other therapies that have gotten approved. So the menu has gotten increasingly complicated. We don't have to cover everything in one consultation also. Sometimes for a newly diagnosed patient with metastatic disease, it's overwhelming. And so we kind of first start off talking about the disease and the symptoms and how we're going to start with hormonal therapy. Maybe we talk about adding some of these new oral agents for chemotherapy. That's enough. That's going to take a full hour. Maybe we save the genetic testing and the genetic counseling and whether to do, germline or what's called hereditary cancer assessment. That's going to be a different day when things have settled down, when we can focus on that kind of question. And we're not going to necessarily discuss all of the possible therapies that could be in their future at that moment. We'll get to that. But really, the initial goal is to get that cancer into remission, get those symptoms under control, reassure the patient that they're going to be around for a while. I still have patients from my 2006 initial clinics that I still see as a medical oncologist. So there are many patients that, maybe they were given a prognosis that wasn't correct, from their local doctor. We try to give them the most accurate information that they can so that they can live as long as possible and anticipate a reasonable future.
So you suggested patients come in with questions,
Mm-hmm.
which is great. What about goals of life? What do you want to know about the patient in terms of their tolerance for fatigue or goals around intimacy or longevity or even emotional upset and fear and depression and anxiety, et cetera?
Right. I do a lot of listening, and those are all valid concerns. Those would be concerns that I would have as a patient if I were faced with hormonal therapy or surgery or radiation. A lot does depend on the disease state the patient is facing. If it's a patient with early prostate cancer, sometimes we do active surveillance for those patients with lower risk disease and try to leave them alone, but not ignore them. Active surveillance is an active process, for example, for these patients who can avoid the harms of surgery and radiation and enjoy a good quality of life without those side effects. So that's an increasingly popular choice for men with what's called very low risk or low risk prostate cancer, and even some men with intermediate risk prostate cancer. The medical oncologist tends to get involved in more advanced prostate cancer, but I counsel patients even with early disease. I kind of act in that way as a unbiased third party as a medical oncologist. I'm not the surgeon, not the radiation doctor, but I treat a lot of patients with prostate cancer who have experienced those treatments, have experienced regret over certain decisions, who had wished they had chosen a different path. So I can counsel them on the pros and cons of the various therapies and the impact on quality of life for localized disease.
Is there ever an opportunity for active surveillance, like within an advanced, perhaps an oligometastatic patient or a patient?
It's a great question. Some of the, most of the data for men with metastatic disease suggests that we can improve survival with good systemic therapy, and that patients with like a single site of metastatic disease on conventional imaging often harbor additional sites if you were to do more fancy imaging, like a PET scan, like a PSMA PET scan. So unfortunately, we're not seeing a large number of men cured with just treating a single spot. But we are seeing life that's prolonged with hormonal therapies, even more intensive hormonal therapies. And some of the clinical trials that we're doing now are trying to treat those metastatic sites like the prostate, but if it's in a bone or a lymph node, with a course of radiotherapy or surgery to target that's called metastasis directed therapy. And then, to stop the systemic therapy once a patient has achieved what's called a complete remission. And a complete remission would be defined as the PSA 0 or very low, and the imaging has shown regression of disease. And that would be an opportunity to stop these systemic therapies and return to a good quality of life. And so that's under investigation right now. I wouldn't say it's necessarily the standard of care, which remains kind of continuous treatment to remain in remission, because many patients do relapse when you stop therapy.
Yeah. Does that ever happen where a patient, I mean, I'm sure 1 in a million perhaps, but in a significant sort of reasonable to discuss kind of way, does it ever happen that a patient will go into remission and it'll be durable and they'll die at 120 in a car accident?
Even in metastatic disease, I have many patients in my clinic where we've taken aggressive approaches and with good systemic therapy and metastasis-directed therapy and treatment of their primary, have gotten rid of the cancer where we don't see it anymore, we can't measure it anymore, and we stop therapy. We're seeing that increasingly more common with more sensitive imaging, where we're able to detect metastatic disease that we had no idea was present in the past. And we even do see it in certain patients that have genetic subtypes that are responsive to immunotherapy. I have about 5 patients, for example, that have what's called microsatellite unstable prostate cancer, MSI high prostate cancer, where they've been able to achieve a complete remission with immunotherapy called pembrolizumab. That's rare. I don't want to say that's common, but when you see this happen, it really blows your mind and you want to keep doing it. And patients being able to stop therapy is kind of the holy grail of a medical oncologist career, is where you can stop your therapy and see the patient do well without the need for that therapy. But I think we're getting towards that. I don't want to say that that's the rule. It is the exception still. We always hope for it, and when it happens, we celebrate with the patient.
No, that's great. And, it sort of gives a bit more meaning to the idea of hope, the hope that you could actually get rid of this thing and move on. You've discussed patients bringing in questions, bringing in ideas about their goals and desires and constructs of life. Now, what are you doing to figure out what to do with the patient? What kind of tests or images, or, what should a patient expect to be prodded, poked, and have to sort of expel to help you along?
Sure. So I sit on the National Comprehensive Cancer Network guidelines. So I've been a guideline member for a decade now, and I would point patients to that. We've actually made a patient-friendly guideline. It's very difficult to tell you all the various possibilities of the menu in a short interview, because the types of questions, the things that we might do for imaging and tests do differ if you have localized disease. And even within localized disease, you might get imaging if you're high risk, for example, and you might not get imaging if you're not high risk. Versus in a metastatic situation, your treatment options and the questions you might ask are very different. But some of the common questions and the tests that we will do in a patient with more advanced prostate cancer, let's say if you've developed metastatic disease, which happens about 10% of the time, 10% of men in the US will start off with metastatic prostate cancer. And that's either because of a lack of PSA screening. We see that increasingly common now during the COVID pandemic, where men have not been getting their PSAs checked, not getting screens, not getting early diagnosed. And the only way that then you come into clinic is if you develop symptoms, either urinary tract obstruction or bone pain or weight loss. And unfortunately, I see a lot of these patients in clinic on a week-to-week basis. So you don't have to be in that situation. You can get screened, you can get early detection, and we know that that saves lives. But if that's not the case, if there is metastatic disease, some of the questions to answer are, what are my options in terms of what's most effective to get me into remission? Things like hormonal therapy, androgen deprivation therapy, some of the newer androgen receptor blockers are going to be part of the menu. Is there a role for chemotherapy? We offer docetaxel, for example, for men with very high volume of metastatic disease or cancer that's in internal organs like the liver, the lungs. I think that's a reasonable question. Is there a role for treating my prostate, even though maybe your urologist told you that the horse is out of the barn and there's no point in removing the prostate? There's actually data that treating the prostate with radiation, even though the cancer has spread, improves survival. So that's a question that you should ask. Am I a candidate to have my prostate treated? Will that help me live longer? What about these other metastatic sites, whether that's in a lymph node or a bone? Can we try to eradicate my disease? It's a common question. And then what are the side effects of all these therapies? How do I survive the best during hormonal therapy? What are things that I could do in terms of diet and lifestyle, vitamins, minerals? If you have questions about supplements, there are many good websites. I always provide a nice resource guide as part of my consultation because it's really hard to answer every single question right away, but there's great resources. I write, for example, for the Prostate Cancer Foundation. They've got a great brochure. There's many other websites. You've got your own here, and we've got many through the NCCN. But I try to get them to develop questions over time so that they go and read some and then they bring them back, and it's a kind of a back and forth discussion. But survivorship is really important. Understanding that likely we're going to be able to get this cancer into remission, have some degree of control, but to understand how to live the best that they can during that time to minimize the effect on their quality of life and the quality of life of around them, their significant others and their family.
Yeah, and that's sort of the mission of Malecare, is to help men live longer and happier lives. But we know that as much as we want to say that and offer that, it's for 100% of men. Once you're diagnosed, there's a change. There's a change in what you see, what you feel, everything. And for some, it's more devastating a change than others. For most, thank goodness, it's sort of in the middle, and it can be modulated for improvement by things that we do in our support groups, by things you do in your office, et cetera. What are the things that you would want a patient to know about the change that they're experiencing?
Mm-hmm.
I mean, is this just part of life, or is this something exceptional that we regret happened to this particular individual?
Sure. Well, first off, there's always an emotional component to being diagnosed with prostate cancer. Some men do pass through a period of loss, bereavement for what they had, stress, anxiety, depression, and addressing that right up front. A lot of the time, this can be addressed through education, reassurance. Maybe they had the greatest fear that their Gleason 6 prostate cancer is going to now kill them. And your job as an oncologist is to reassure them that they don't actually need treatment, that they're going to do well and have no higher mortality than a normal guy without cancer. So I do a lot of that, a lot of education around their disease. Just getting correct information can alleviate so much of this prostate cancer specific anxiety. But also listening. What are their concerns? Writing down your concerns, getting patients support either through a support group or through a trained counselor, maybe even a psychologist or psychiatrist if there's a severe reaction. Having loved ones who are around you, whether that's spiritual or partners, can really help. So communicating with patients' families and getting them involved really can help. But setting the stage then for what are the most common side effects and how we're going to address each of them so that they can live as best as possible. A common, drug that we use is androgen deprivation therapy. These are shots that lower testosterone. And so that's a a common one where the list of side effects, include things like muscle loss, loss of stamina, loss of libido or sexual interest, erectile dysfunction, loss of bone density, some impact on cardiovascular fitness and fatigue. And so I do a lot of educating around exercise, sexual health. I think it's important often to keep urologists involved because of their expertise in erectile dysfunction management, urinary symptom management. Many urologists are comfortable giving these systemic therapies as well. So we can often have a partnership where, we're both treating the patient according to our level of expertise. And I educate them about monitoring for bone density, managing hot flashes. Certainly there's high variability, just like women going through menopause, men going through what I call menopause can be very variable. Some men, it's really severe and debilitating. And I want them to be proactive in communicating what they're experiencing so I can manage that, whether that's just the hot flashes or the fatigue or, stress-related mental health issues.
Yeah. Do you find we have a number of talks on disparities and such that will take place on different days, but while we have you, do you find Black men presenting quality of life issues in a different way than white men?
That's a great question. I think Black men in the United States do face a disproportionately more aggressive prostate cancer, and whether that's due to access, screening, early detection disparities, I think it's across the board. We see disparities right from the beginning in access to screening. We do see that men who are Black who have equal access to care, such as in the VA healthcare system or who are in clinical trials, actually do very similarly, if not better, than matched white men in clinical trials. We've shown that in a series of clinical trials comparing men by self-reported race treated with immune therapy or these newer hormonal therapies or chemotherapies, that they don't have different necessarily efficacy, sometimes a little better, but they may have different toxicities. Black men also face a disproportionate increase in their body mass index, in hypertension prevalence, in renal disease and diabetes, and they carry that into their journey of prostate cancer. And so you have to account for that. And so, for example, in our recently published ABBY race study, where we studied abiraterone, a commonly used hormone drug, prospectively in Black and white men, we did find similar efficacy, although Black men had a little bit of a better efficacy in terms of PSA outcomes. But we did see noticeable differences in efficacy, in toxicity. And the safety reporting of abiraterone did differ in Black men, where we saw more hypertension, more hyperglycemia or high blood sugar, more electrolyte problems like low potassium. And I think, the underrepresentation of Black men in our clinical studies is really a problem that, if you don't account for the populations that are going to be receiving these therapies in the clinical studies, then you don't know what to look for. So I think that was the main message, is to be inclusive in the studies so that you can understand what those differing toxicities may be by race and by ethnicity.
All right. And within clinical trials, we have one kind of person, a person who passed through all the requirements and barriers to, but there's real world evidence, what's called real world evidence, which is basically all of us. And what we're telling
everybody else.
Well, everybody, including the trial, everyone else. Yeah. What disparities do you see emerge from the folks who pop into your office? What's your actual real world, experience with your patients without necessarily naming folks?
Sure. So, the real world evidence around disparities, is profound. You see a lot of Black men never even getting to comprehensive cancer centers, not even coming to see me. So we see, particularly in rural North Carolina, the disparity starts right from the beginning in terms of having that discussion with a primary care, establishing trust so that there's shared decision-making around prostate screening. We see that disparity in the ordering of a PSA test, the ordering of a multiparametric MRI to diagnose a man, to get a biopsy, to get a timely referral for adherence, for getting into the urologist. So we see it outside of clinical trials all the time. And so, what Duke is doing and what we're doing is trying to establish algorithms, navigation systems to broaden the knowledge base of our primary care physicians, and to improve that access, because access is really paramount. And because Black men are starting typically globally behind in their race against prostate cancer, they do face that higher mortality rates, about twofold, and they present with more metastatic disease, which is unfortunate. And the pandemic is really just exacerbating those disparities, not making it better, because the pandemic preys on those who are less fortunate, those who are savvy and educated and have a high income or high socioeconomic status will be able to access a lot of these pathways that a man who, may be disproportionately affected is not going to impact. So we see these disparities in the real world. In terms of toxicities, I don't particularly notice major differences in sexual function or impact on sexual function based on these treatments, but there are differing concerns, by race. And so I think it's important to individualize your treatment, to listen, to understand the patient in front of you and their health and their concerns, because it's going to be different. Even within Black men, there's going to be a wide variety of concerns, and within white men, a wide variety of concerns, not to just label somebody as something and, put them in a box. So it's very much individualized and personalized.
Right. And we're going to have a very interesting conversation with another physician. Why do we even ask on intake, are you white or Black?
Right.
Yeah.
Right.
What's the implication? As we close this out, and a wonderful conversation so far, I mean, the key question I think every man and their family members will have is, how am I going to die from this? What is it, aside from like the palliative care issues and that we could talk about and will in another talk with someone else, how does prostate cancer kill us?
Sure. It's an important question. And I guess the first question I would ask is, what's the chance that it will kill me? Because prostate cancer, it affects about 1 in 7, 1 in 8 men. And of those patients, it only kills about 1 in 6 to 1 in 7 men. So that makes prostate cancer the number one survived cancer. So it is important to ask about the chance of success, meaning cure, first. And if you're cured, you largely would have a normal life expectancy. And so then you don't have to ask about how you're going to die. But if you're facing metastatic disease, stage 4 disease, if the cancer has spread, I think it is a reasonable question to start to plan for the future. Of course, the goal in the immediate term is to get the cancer into remission, and that remission can often last years. And then a patient will go through a series of progressions and remissions with our subsequent therapies. We have a lot on the menu that can put the cancer back into remission, but ultimately for patients with stage 4 disease, death is often an inevitable thing that happens. And it can vary. There are patients where prostate cancer fatality can be made comfortable, where patients proactively go on palliative care measures. They have their pain under control. They never get admitted to the hospital. They are surrounded by their loved ones or taken care of at the home. And while there is suffering, there's no doubt there's suffering. This can be minimized by a proactive palliative group and team, whether that's from bone marrow failure or pain, particularly complications in bone, or pelvic pain or urologic problems, urinary obstruction. We try to mitigate all those side effects proactively. There are a population of patients that do end up getting admitted to the hospital and often prolong their suffering through further chemotherapy, even in the last weeks of life. And we try to have that engaged discussion and involve our palliative care colleagues early so that a goals of care discussion can be had about reasonable expectations. And I think sometimes that's the hardest thing, is when to stop therapy and when to have that realistic conversation about, because the menu is so long, it's often, when to have the discussion about when it's time to stop. is very difficult, especially with all the new therapies coming. I personally have a large number of patients who are very much looking forward to, for example, PSMA lutetium coming in early 2022. And if I could just hang on a little bit longer for this next therapy coming out. And that's very challenging. We struggle with that tension between making sure that their end of life is respected, that they're comfortable, but not giving up on hope with therapies that could extend their life and time with their loved ones. So I think there is a balance to it. And, just making sure that they have a realistic sense of what their prognosis is so they can make an accurate decision for themselves and their family.
Yeah. Do you think there's ever a time where you should you have told or might tell the patient it's time to stop talking to me and probably start talking to a gerontologist or a palliative care person or a hospitalist or any of those other folks?
Yeah, I think our team at Duke here has really identified, when a patient is in likely the last year of life, that's probably the time to do that. Now, we may be wrong. We're frequently wrong. If we ask ourselves, would we be surprised if this patient was not alive in 6 or 12 months? That's when you should start to really make sure that you're engaging with the patient on that goals of care, involving a palliative care specialist. You could be wrong. I have patients where I've thought that, but then, you can get that patient into remission with a new therapy that could last years. But it's never too early. You'll never regret making sure that you're focused on symptoms.
Yeah, no, and that's a great way to consider it. Would you be surprised in 6 or 12 months or so?
Yeah.
So we have a virtual audience this year as we did last year. So I have to imagine what 4,000 people behind me might be thinking or so. And I could feel people throwing eggs at me saying, I still don't know what kills me. What about, can you help? I mean, let's go dark, and we'll come up with some, let's really go, help us visualize how does prostate cancer cause death? And also, let's go even darker. How does it cause pain?
Okay. Well, let's just give you some real life examples just from the past 2 weeks of my own clinic without naming any names. All right. So I lose patients regularly. I also have a lot of patients that I celebrate longevity with. But when you're a medical oncologist, you live a life that is a roller coaster, of periods of time where you do lose patients. And death from prostate cancer is just as varied as life with prostate cancer. So, for example, a common pattern of spread of prostate cancer is in the bones. And when cancer that has metastasized to bone, when that becomes uncontrollable, when we cannot any longer control that disease with hormonal therapies, immunotherapies, radium, docetaxel, cabazitaxel, when we've tried everything and we face maybe even clinical trials, that's what I do for a living. And some of the patients that I've lost recently, they participated in clinical trials. And, unfortunately, sometimes they don't work either. But we do encourage patients to seek out a clinical trial center if they're fit and able to travel. The most recent patient I lost, he was suffering from pain. He had pain in his pelvis, in his ribs, in his back. He required long-acting opiates, morphine, oxycodone. He required radiation. We needed a nurse to come out to his house. He fortunately had a significant other, a spouse that was very loving and cared for him. He was able to stay at home. He avoided hospitalization, which was, his goal was to not die in the hospital. And he was comfortable. He had support. He had paid his best wishes to all of his family and friends. They had, he had stopped things about 2 months before he passed. Unfortunately, the average time that a man spends on hospice right now is only about 2 weeks. So that's way too short. It's important to realize sometimes when the end is coming and not to prolong it unnecessarily, but to make sure that patient is looked after. And, what is a good death? Would be a death with dignity, a death without undue suffering, where they can spend as much time with their loved ones as possible. Maybe they have a goal to get to a particular life event of a family member or see something in particular. And a second patient, had a very nice trip to see the Northern Lights, and made that his wish at the end, was able to get him there with a lot of medical care. One of the types of prostate cancer that's most aggressive towards the end of life, we call that small cell or neuroendocrine prostate cancer. This is a type of prostate cancer. It's very hard to treat other than with chemotherapy. And we're doing a number of active clinical trials of some new approaches to treat this disease. But this behaves more like lung cancer. It doesn't make PSA. It can spread into your organs. Fatigue, nausea, loss of weight, pain, and suffering from all those symptoms can result from that spread. And, when that develops, it's really important to make sure that, realistic goals and expectations are understood, that we may be able to fight this cancer, but we may not be able to cure it. But enrolling on clinical trials is really kind of the emphasis for a lot of these patients. Bone marrow failure is a real issue. One of the hardest things at the end of life is transfusions and when to stop transfusions. Transfusions can sometimes improve quality of life, but they don't necessarily improve quantity of life. And sometimes they don't even improve quality of life. You can have a patient with debilitating fatigue and they're anemic, but just giving them a pint of somebody else's blood doesn't actually fix that. And when you're starting to see that futility, that lack of a bump in their quality of life with transfusions, that's probably a good time to think about what you're doing. What are you trying to accomplish? Are you just treating a number? Are you treating the patient in front of you? And, that is one of the hardest things in oncology, is when to stop some of those efforts. But it's really about a shared decision. It's not me just saying what to do, but really trying to understand what their goals are.
Yeah. I mean, that's the ultimate question is, what can the two of you speaking together and sharing together come up with that provides the ideal situation, or as close to as possible, for the guy.
Being on his team, that's kind of trying to be a good listener and make sure that we're advocating for our patients.
In fact, that's another brilliant sort of construct, that you're on his team.
Right.
I mean, people probably say that it's probably, on the nurse's station, a little card or something, but to genuinely understand that, that you're the patient, I am not alone. I've got you, I've got whoever I know, 20 other doctors and investigators that I'll never meet, that you're conveying their wisdom to me to make it useful for me. But it's my team and I'm the boss.
That's right.
Yeah. Dr. Armstrong, thank you very much for this wonderful conversation. Helpful, I don't know, inspiring is the right word, but certainly provocative in a good way, to sort of invigorating. That's what I've been, a genuinely invigorating conversation that all advanced stage patients should hear, and then sort of invest in their own understanding and their own conversations with their doctors. And thank you for being part of our faculty at our conference today.
Absolutely. Thank you, Darryl, for this invitation. I enjoyed our conversation.